Okay, we'll go ahead and get started, and what we're going to do is just do a quick overview of a few things, and then introduce the clinic here in Denver and the clinic in Johns Hopkins, perhaps talk a bit about differences and take any questions that you have. Each of us is giving another talk this afternoon in more depth on the various topics. So I'm going to give a brief overview of endocrine issues in Klinefelter syndrome, and this is emphasis on brief. I really just have a few slides and then a few slides about our clinic. I'm going to talk mostly about hypogonadism or inadequate testicular function in individuals with Klinefelter syndrome. And this is a primary testicular failure. What that means, and we'll talk about it more this afternoon, is that this is a problem in the testis itself. It's not a problem in the regulation of the testis. So the central hormones that are responsible for the onset of puberty are normal in individuals with Klinefelter syndrome, but the testis itself is abnormal and unable to respond properly to the hormones LH and FSH that come from the pituitary gland. Once pituitary puberty starts, in other words, once the pituitary activates at the age of 10 or 11 or 12, what we see is that the pituitary attempts to derive response from the testis, but the response from the testis is inadequate, and there is no feedback from the testis. What you see hormonally is that because sperm cell production is abnormal, and again I can go into that in more detail this afternoon, the hormone FSH rises. So the rising FSH tells you that there is inadequate sperm production. When testosterone production is abnormal, the hormone LH rises. So in a way, FSH and LH will give you a view of what is happening within the testis. And the elevation of FSH and LH is called hypergonadotropic hypogonadism. So FSH and LH are gonadotropins. So this is hypergonadotropic hypogonadism, okay, as opposed to central problems in which the gonadotropins are low, which is called hypogonadotropic hypogonadism. Now, one thing to keep in mind is that LH and FSH won't be elevated prior to puberty because the brain is not attempting to make the testis do anything, and we actually don't know what causes puberty to start. So we have inadequate testosterone production in individuals with Klinefelter syndrome, and one of the questions that comes up all the time, and we don't really have answers to, is what's the proper timing of testosterone therapy? Should it be in early childhood? Is there some action of testosterone which is missing when people can't make it adequately? Should it be in later childhood as the testosterone is slowly beginning to rise? Perhaps this would have an effect on small penis. Maybe there's behavioral benefits. And maybe there are physical benefits of low doses of testosterone. There is evidence that little boys do make some testosterone. So perhaps there is some benefit to starting testosterone. We don't know the answer to that. Should testosterone be age-driven? We know that the normal time of puberty in boys is 12 to 12 and a half years. Perhaps we should be starting testosterone at that time. However, there is quite a bit of variation, as you know. Some boys start puberty early, some boys start puberty late, and perhaps if we pick a particular age, we in fact will be starting testosterone too early or too late for an individual boy. Another approach would be to let the body tell us when testosterone is needed. So as I said, when there's inadequate testosterone production, LH begins to rise. So perhaps what we should be doing is starting testosterone when LH is beginning to rise and the body is telling us that there's inadequate testosterone production. We could also time testosterone replacement therapy based on physical effects. So for example, if gynecomastia occurs, what that tells us is there's inadequate testosterone production, and I will go into that in more detail why that occurs. So perhaps we should wait until there's really strong evidence that testosterone is needed. And I would have to say that historically that's been the approach, to sort of wait and have the kid prove that they need testosterone, as opposed to a preemptive or prospective initiation of testosterone. So graphically what we see then is that testosterone in boys, there is some, so perhaps we should be replacing it. It then begins to rise around 12 or 13 years of age. And so this is one time when we might begin testosterone. In other words, should we be just trying to imitate what an individual boy would otherwise do? Should we wait until they get to a higher level of testosterone and LH is beginning to rise? Should we wait until the testosterone is actually clearly failing so that you reach a peak and then it begins to fall down, which is a common occurrence? Or do we wait for clinical signs and symptoms of low testosterone? What are the consequences of low testosterone? They include reduced body hair, decreased muscle mass and strength, increased fat mass and an altered fat distribution, so it's more feminine in distribution. There can be unfavorable cholesterol changes, such as increased LDL and reduced good cholesterol or HDL, decreased hemoglobin, obviously decreased sexual function and interest. There can be effects on bone, osteoporosis occurring, and there may be effects on mood and behavior. The benefits are obviously virilization. Those are the outward signs of pubertal development, promotion of normal sexual function and development, so that you maintain these kids similar to their peers. This can contribute to self-esteem, improvements in muscle fat development and muscle development and fat distribution, effects on body proportions. So one of the things that testosterone does is eventually limits the length of the long bones. So one of the reasons that boys with Klinefelter syndrome become tall is that they don't have this effect on the bones, so the bones grow longer and they grow, and so the patient grows taller. So testosterone can promote bone maturation and limit the excessive height that can occur. And testosterone also promotes spine growth so that you have different proportions. Mineral accumulation is affected by testosterone, so bone density may be improved, and prevention and or treatment of gynecomastia. And as you know, there are lots of questions about whether testosterone therapy affects behavior, and that's one of the things many folks are actually looking at. The disadvantages are all those things that happen to boys who have testosterone. So acne, increased sexual activity and interest, increased strength, which can be a problem if the behavior is a problem, and short stature if it's started too early or is titrated too fast. There are many options for testosterone therapy, which I will go into in more detail this afternoon. They include oral, not in the United States, however. It can be injected. It can be done through the skin with transdermal gels or patches. There are buccal or preparations that are used inside the mouth. There's a new one that you roll on into your armpit, and there are testosterone implants. And they each have their advantages and disadvantages. Other hormonal abnormalities that occur include hypothyroidism, diabetes, generally related to excess body fat and weight gain, low bone density related to common occurrence of vitamin D deficiency because of diet. It's actually common in adolescents in general. Low muscle mass can affect bones. Delayed testosterone replacement because of the effect of testosterone on bone mineral accumulation. And uncommonly, overt osteoporosis with fracture. So let me just tell you very quickly about the clinic here. Many of you know about this. The goals, as Susan said, is comprehensive interdisciplinary clinical care, research, education, and support for children, adolescents, and young adults with XY chromosome variations. Dr. Tartaglia is the clinic director. She's a developmental and behavioral pediatrician. She will perform general medical evaluations and does medication management of behavior, emotional disorders, hyperactivity, etc. And I have to tell you that I think Nicole is one of the best medication managers I've ever seen in terms of behavior. She's not throwing drugs at kids. She's really very thoughtful about ways to manage medicine. Susan is the backbone of the clinic as the genetics counselor and research coordinator. We also have two child psychologists who perform evaluation of social and emotional problems, behavioral problems, and do developmental assessments. And we have 3 neuropsychologists who will perform testing for learning disabilities, executive function, and hyperactivity. The patients are evaluated for speech and language problems by Jackie Frazier, Shelley Pfeiffer, and occupational therapy. So activities of daily living, and motor skills are evaluated by occupational therapy. And I see the patients for evaluation of their hormonal problems, such as testosterone treatment, obesity, diabetes, thyroid disorders, growth, etc. We also have a nursing, social work, and research assistants. Patients will get evaluation of all XY chromosome variations. We see infants, children, and adolescents. Some young adults, depending on what needs to be evaluated. In other words, if they still are having sort of adolescent issues that have not been addressed. And evaluation team members are individualized to what the patient needs. In general, private insurance and Medicaid is accepted. We are, however, out of network for most out-of-state insurance companies or Medicaid. Medical evaluations are usually covered, and different plans have different coverage for psychological assessments. Susan Howell is the person to contact. She will send information to the families, intake forms. She will collect the intake forms and figure out what sort of evaluation is needed and set that appointment up for patients. The waiting list is currently about 6 to 12 months for new patients. And some of these evaluations are very long. They may last all week, or they may just be one day or so. Thank you. I think Cynthia's going to talk to me. And I think we take questions maybe at the end. What do you guys want to do? I think so. Yeah. Oh.
Thank you. I'm just going to be introducing what I do briefly. Our team at Hopkins is multidisciplinary, but I'm the neuropsychologist there, so I'm just going to be talking briefly for those of you who may not be aware of what neuropsychology is and what the kind of work that I do. All right, so neuropsychology is a subdiscipline of psychology, and psychology just, very broadly is a study of mind and behavior. And there are many types of psychologists. So there are industrial organizational, experimental, forensic, work in the jails, school psychologists, sports psychologists, clinical psychologists, so that there are many different types. Neuropsychology is a subspecialty typically of clinical psychology. And so the focus of neuropsychology is on the brain, brain disorders, relation between brain and behavior. So if there's any abnormal functioning, is it related to abnormal brain? So that's just at a very basic level what we do. So the diseases and conditions that neuropsychologists assess are varied. Anything affecting the brain, so head injuries, toxic exposures, including drug dependence, carbon monoxide poisoning, for example, a lot of lead paint stuff in Baltimore, brain diseases such as Alzheimer's disease, Huntington's disease, Parkinson's disease, any of the neurodegenerative disorders like that, as well as learning disorders, so specific learning disorders as well as attention deficit hyperactivity disorder, and then also psychiatric disorders because we are clinical psychologists as well, so we also look at complaints and behavior problems that may or may not related to what we call a broken body part, anything wrong with the brain necessarily. So there may be personality problems, or there may be other sort of psychiatric problems that may or may not be related to adjustment or chemical abnormalities in the brain as well. So the role of neuropsychology in XXY, the way I see it is, we determine whether cognitive processes are normal, just like we do with every patient, and if not, to characterize them. In other words, to describe the ways in which they're abnormal. And to determine whether emotional factors are contributing to or even solely responsible for the patient complaints. The difficulties may or may not be related to XXY, and that's one thing I'm always keenly aware of. We have many patients who come in and they know they have a particular disorder, and then it's natural to make the link between the disorder and the complaints. And they may or may not be related, and then offer diagnostic impressions and treatment recommendations. So how do we do our jobs? When a patient comes to see me, I interview them and others, so if they're family members, interview them as well about, what's going on, why are you here, what are you concerned about, and then paper, pencil tests, computer tests that include, IQ tests, tests of attention, other sort of what we call cognitive domains, so anything related to sort of the basic domains that support the way we think, so verbal skills, memory, visuospatial skills, executive skills, and also psychiatric symptoms and personality factors. Okay. And then there's a review of all the other information, so the medications the patients are taking, any blood work that's been done, brain scans, which may include sort of structural or functional brain imaging, any other medical records, any other prior neuropsychological examinations, and sometimes school records. And at the end of the day, determine whether the patient's results are normal or abnormal. If they're abnormal, then, like I said, characterize, describe what is abnormal about it and what parts of the brain may be abnormal because of what we're seeing on testing. And then to apply a diagnosis, what's causing this abnormality. And then, well, I'll talk about this more later, but then, to make treatment recommendations. So we'll be talking about that a little bit more when we talk about our center. So I believe Dr. Rao is next.
All right, good morning. I'm Pravin Rao. Very privileged to be here and excited to be at this conference for the first time and meeting a lot of you. As you know, Cynthia and myself, as well as a colleague, Adrian Dobbs, have been initiating forming this multidisciplinary clinic at Hopkins, and we've formulated a team and started seeing patients, and we're definitely excited also to hear from you about, as we move on, how we can make this a resource for you and make it useful and kind of work together to advance the field and get patients and families where they need to be. So as we know, this talk is called What We Know. So I specialize in urology and within that male infertility. And so I'm just going to give a few slides on the overview of fertility, although I'll be giving another talk in this room at 1:30 on that topic. And then we'll just introduce a few of the other members in our clinic and what they do, their interests. And a lot of that is just in your handouts as well, which are available to you. So we don't have to dwell on it here, given the time consideration. That way, hopefully, we can keep some time just to have some Q&A right now as well. So I went to Johns Hopkins for medical school, and when you do that, you can't go 10 minutes without them cramming down your throat all the different people that have been there. So I just thought I would share a little bit of that with you and how this is part of our kind of tradition and interest in keeping things going. So first thing in terms of fertility, one of the big things with Klinefelter syndrome and infertility is that really 10 years ago, 15 years ago, was barely even on the horizon or thought of it as an option. And things today are quite different. So I won't go through this in detail, but a few things I wanted to point out is that in the past there have been reports of spontaneous conception by a Klinefelter father without any assistance, and also in a non-mosaic patient. So we just learned what mosaicism is. So in a patient with just XXY cells having pregnancy naturally. And then finally, at the end of here, the first Klinefelter syndrome patient to have a child born with the assistance of testicular sperm extraction and ICSI was in 1997, so around 16 years ago. So moving forward, again, we're going to cover a lot of this later on. But in the endocrine system here, as Dr. Zeitler pointed out and described quite well, is key to fertility because this is what is stimulating sperm production. And again, the problem here is primarily within the testis. And so this is a picture just to, I just realized that I did not fill up my talk in the wrong one. It pulled up here. Here we go. Let me do this. There we go. So at a glance, with XXY patients, about 5% will have a few sperm in their ejaculate. And the studies vary anywhere from 5, sometimes 8, and a little higher. But about 95% of them, most importantly, will have no sperm in their ejaculate, and the term for that is azospermia. And different techniques have been proposed and performed and tested with regards to sperm retrieval. And the most common in the past has been TESE, or testicular sperm extraction, and that's just opening up a small portion of the testis to take some tubules out. But as we've found over time, there are specific small regions or pockets within the testis that are making sperm. So a random approach may not be the most efficacious when it comes to finding the sperm and leaving as much tissue behind to continue to function and make testosterone. So to that end, microdissection testicular sperm extraction, or micro-TESE, has emerged as a way to have better yield of sperm or higher rates of finding sperm while leaving behind as much tissue as possible, but it involves a slightly larger incision in the testis and dissection under a microscope to try to do that. And then quickly, just to give the broader understanding, as Dr. Tartaglia showed this morning, even once you find those sperm within the testis, it isn't something that you can use that to get pregnant naturally with. So we have what are called reproductive endocrinologists. So I specialized in urology, whereas our colleagues in reproductive endocrinology specialize in OBGYN and then do a fellowship or subspecialty training in reproductive endocrinology. And they do these techniques, and ART stands for Assisted Reproductive Technologies or Techniques. And so IUI is intrauterine insemination, and this one usually isn't an option for Klinefelter patients because you need a certain number of healthy swimming sperm. And as you can see in the diagram, those sperm are then washed and injected into the uterus where they can then meet the egg. But more relevant for this conversation is the use of IVF, or in vitro fertilization. And you can see on this plate a bunch of tiny little drops, and in each of those drops, sperm can meet with an egg in a very tiny space. Rather than hoping the sperm will meet them in the large uterus, they're meeting in a droplet of fluid, and that can help with their fertilization of the egg. And here you can see baby Louise, which is the first baby born from IVF. And intracytoplasmic sperm injection, or ICSI, is a technique where, let's say you don't even have enough to put them in a droplet. In this pipette here, you can barely see one little sperm there, and so that can be injected directly into one egg to ultimately cause fertilization, and then that can be grown out into an embryo. So in terms of the men, that's our focus here in XXY. So some of the questions we have, as Dr. Zeitler mentioned, we know we have different options with regards to hormone therapies, and mostly testosterone can work to shut down some of the stimulation of the testis and decrease sperm production. And then we have other options in terms of ways to try to stimulate the testes directly and increase sperm production. And so there's a lot of questions regarding both stimulating sperm production that could be retrieved by ejaculate, as well as trying to optimize our chances of finding sperm when we go to the operating room and do micro-TESE. And in terms of some of the questions we still don't know, there are many, but they include optimal timing for trying to collect sperm during puberty, optimal retrieval procedures and the timing for those, predicting success for sperm retrieval. So this is a huge one because we need to be able to counsel patients and give them accurate, within just saying, okay, about 55 to 70% of our patients find sperm, we'd like to be able to say, and you within that group we think are more likely, less likely, and how much so. And as we'll talk more in the other session, we don't have too many very good predictors for that. And then again, trying to optimize success with different hormone treatments, and then finally, in basic science research, trying to find better ways to stimulate the testes to make more testosterone. So, as we said, more coming. So then a quick introduction to the Johns Hopkins Klinefelter Syndrome Center. As I said, so this is where I thought I was going earlier with Dr. Klinefelter and his time at Hopkins. So obviously he did medical school and residency there. It was actually during his time at Massachusetts General with Dr. Albright, and he actually credits Dr. Albright with this observation where they saw about 9 patients and published on patients with the typical 3 findings of Klinefelter syndrome. which is the stature and the small testes and hypogonadism. He then came out and finished his career back at Hopkins and did a lot more contributing to the knowledge base here. As I said there in 1942, he described the syndrome, but I think one important and interesting thing here is that in the second bullet point here, he even back then acknowledged that these patients can look entirely normal and easily go undetected, especially without a careful exam of the testes. And that has only become more and more apparent as time has gone on, and I think that's what warrants such an individualized approach for these patients. So again, as I mentioned, we'll just quickly talk about the goals of our center and what we're aiming to do, and then I probably won't go in too much depth on all of our providers. So really what we want to do is develop standardized testing procedures for these populations, develop treatment guidelines for men with sex chromosomal disorders, and then advance the scientific knowledge both in diagnosis, pathophysiology, and knowing how to treat these patients. So maybe we'll skip through these. I think you guys have all these in your handouts. Cynthia, I don't know if you want to come up. We'll really, when it comes to the multidisciplinary approach, Dr. Zeitler kind of mentioned the way that things are done here in Denver. And for us, we have something called Hopkins USA, and they help coordinate appointments and patients needing multiple appointments with different departments from around the country. So the way we have decided to set this up includes patients calling Hopkins USA, and they all have direct access to our scheduling and our secretaries to give priority to try to fit everyone in a short period of time. And we help figure out who they need to see based on various questionnaires and paperwork that will be sent, etc.
We can see
Yeah.
it. I can't remember what all we put in here. Just basically the way that the center works at this point is that after all the examinations are completed, then everyone who's seen a particular patient who's part of the center, we communicate with each other and say, okay, what do you need to know about what I found? And so we talk about how the findings from one discipline may have impact on the treatment from another discipline. And then the patients will receive written reports that can be shared with their treating physicians. And one of the things that we are sort of figuring out is that we sort of gone back and forth whether we want to give one mega report based on everybody they've seen, and here's our product versus, you saw me, so I'm going to give you my report, and you saw an endocrinologist, so you're going to get that report, and urology, so you're going to get that report. And I think that we're sort of finding out that with adults it's sort of better to keep everything separate, because unlike with children where, everything that they do on a daily basis sort of has impact or influence on everything else they do. Adults, our lives are more circumscribed. So, your work situation is maybe not influenced very much about whether you're fertile. So it's different situations with adults versus children. So at this point, everybody I think is getting separate reports from each person who's seen them.
And so one also distinction from what Dr. Zeitler presented, he presented all the key team members that are all part of the Children's Center here. Correct me if I'm wrong. Whereas in our center, most of us really trained and specialized in care for adults. Though we were particular that we wanted to have a pediatric endocrinologist who is experienced in the field available for patients, because we are so far from Denver and we need to have some resources available for patients as well. But at the same time, definitely the mass of our focus includes adults, but we just want to have things available for children as well. And I think of all of us, the most overlap in our field with the pediatric population would be myself, just when it comes to fertility preservation. So with that, this is just, it has our website there and also the number for Hopkins USA, which you can easily find later as well. So Dr. Zeitler, if you'd like to come up, and how are we doing on time?
It's 12, so we've got some time.
Yes.
Okay.
Good job getting everybody back on time.
We talk quickly.
Probably too fast for everybody, so questions? Yeah, go ahead.
My son has low muscle tone in the weak core.
Yeah, I'm listening.
once he starts,
This ear works better, so I just turn it.
once he starts testosterone therapy, will that improve?
I can't talk about him as an individual, but in general, yes, testosterone therapy will improve muscle mass and strength. That's one of the reasons men are stronger than women.
I actually have a question for the Hopkins people. Is there anything that you think KS&A could do to work with the developmental pediatricians and other specialists at Hopkins so that they also develop a children's portion to the Klinefelter or possibly X and Y chromosome disorders? Because there's a huge need, obviously, with a 6-month wait to get into Denver.
Yeah, and that's something Cynthia and I were talking about earlier today. So we have a huge, pediatric developmental center in Kennedy Krieger there, and there's huge overlap with autism.
Yes.
So that is on our radar and something we're interested in both either collaborating with or having them kind of rise to the occasion as well. So we're happy to work with KS&A and put people in touch and talk to people as necessary.
Because
Try to make
certainly
that
we have several of us as volunteers who would be happy to meet with them to detail what the needs are and why it's important to have that sort of East Coast clinic.
Sure.
Yeah, that may be important because we just got a new chair of child psychiatry.
Wonderful.
And,
Yes.
and he's very open,
Yes.
but he's also very overwhelmed. And I think to make things a priority,
Yes.
there has to be, a show of need. It can't be just me
Yeah.
talking to him and saying, can you help me here? It's got to be, a larger effort. So,
I mean,
yeah.
I would go in from the kind of tie with autism spectrum disorders and with, ranking high on those domains, but not quite meeting. Because I know that they, that's a way of getting some interest.
I think it's interesting. One of the challenges probably is that so many of these boys present well.
Yes.
And so developmental centers are not thinking hard. They're so swamped with kids with severe behavioral disorders, severe
Or they're
developmental
just
disorders.
sending them to speech therapist.
Yeah, exactly.
Yeah.
So I think that's a challenge to convince somebody that, they should take some energy in this area.
Yeah.
So Cynthia, how many letters do you need and where do you want us to send them?
Yes.
That's not a problem.
With a check attached.
Yeah,
With a check attached. That'll get their attention.
there you go, I
And
like
I might
that.
add that the Denver Clinic can easily show anybody at your administrative level how much patient demand there is, and I would be happy to talk to the Kennedy Krieger people in their developmental centers, I know those people pretty well, about our, I can easily do the training.
Yeah, not just numbers, but also, I think, pathology would be.
Pathology,
Yeah,
absolutely.
right.
Up top, yeah.
Hi, my name is Lorena. I have 2 questions. Will your PowerPoint presentations be online for us to share?
I think that's the plan.
Yeah. Put them on the KS&A website.
Yeah, they have in the past.
Great.
Yeah.
And then my
It's really
second,
helpful.
I'm sorry.
Along with the videos will be.
Yeah, somebody's sitting up there, so.
Yeah.
Yes, your second. You
Yeah.
have your question, right?
Yeah, my second question is, how often, I'm just wondering, because there could be other conditions, not only XXY or KS, like, have you seen, for example, 22q deletion, like other genetic conditions with this within the clinic, or is that not so much?
Well, here in Denver, we actually have a 21Q clinic. So it's really a separate set of issues, and it's quite common. It's common enough to actually have a sort of clinic team that sees the 21Q kids. And that's true for Prader-Willi, Down syndrome, a few others that are sufficiently common to warrant that.
Yeah, at Hopkins, we wanted to start simple, and so we sort of got everything worked out, and so we just, at this point, are concentrating just on XXY.
Here. In the red.
Yeah.
Okay. Well, we're the parents of a young adult with Klinefelter syndrome, interested in perhaps bringing him to Hopkins. Can
Hopkins USA people, you know, and how much pressure they put on us. I mean, I certainly, I know that Dr. Dobbs and I think you and I mean, all of us have sort of prioritized these. I really don't know. I mean, my typical clinical waiting list, for example, is, you know, 6 months, but I know that I've gotten in Klinefelter patients much sooner than that. I mean, I can't say, I know that it's not as long as what they're doing in Denver, but it depends on a lot of issues also with, you know, your travel as
Right,
well.
so-
I have contacted the center, and I went through the process of getting an appointment. And before you can even set up an appointment, you have to give them all the paperwork that you have from any of your doctors that you're currently seeing. And then after they receive all the paperwork, then they'll talk to you about scheduling an appointment. And mine is upcoming in September, and it was a good 4 months from the time that I had all the paperwork there before I was able to get an appointment.
Let me just address that, because it's a really good point. And I know it's, I mean, as a patient, I know it's incredibly frustrating to get records to a
Yes.
consultant.
I had difficulty with
Yeah,
the doctor.
it took me, you don't even want to know how long it took me to get my screening colonoscopy schedule. Because the paperwork wasn't going right. On the other hand, it's incredibly important, because here we do this for all our patients, not just Klinefelter patients. We used to get kids in without adequate information. We didn't know what had been done, and it was really a wasted visit. So as frustrating as that is, it is actually incredibly important, and, you know, just stick with it and make sure the stuff, that they receive it, that it gets sent. You just have to stick with it.
And then, because I have an adult child, the office will constantly say, well, why are you calling for the records? You know, because my son's not going to be on top of it. So, you know, you have, if you have an adult child, you have to make sure that you have that written in his file that you're able to, and then they still question it.
Yeah. You've been very patient.
Thank you, and this question is not actually related, it could be for the urologist or for anyone from Denver. I have a son who's 11, who's XXY, and maybe going to your session will address it. And the person that spoke about the different types of Klinefelters, if they will be able to have sperm naturally, like some of them do, and it's the mosaic thing. See, we had a prenatal visit, he's 11, so like when I was pregnant, which we're very blessed because we kind of had a roadmap of what to expect, but we were told, you know, he'll be infertile. So that mosaic thing, or we're not really sure like, what step to take as far as the urology. I mean, he does have at Children's Memorial in Chicago a pediatric endocrinologist, but she's not a specialist in Klinefelters. But you know, as far as testosterone, a bone density test, but as far as fertility, you know, we're not really where we stand there.
So are you saying?
I think that the technology has preceded what we were told.
So you've not had genetics counseling since the in utero diagnosis?
Exactly.
Well, so that's number one.
Right, so it's changed so much.
You-
And we went, the first time we came,
Right.
we were here 2 years ago, he was 9, so he was, you know, pre-puberty, now he's kind of getting there.
Yeah.
And we visit the endocrinologist once a year, and I think she said she's gonna be checking it with a bone density test to decide when to start testosterone. But again, like I'm sure she's an excellent pediatric endocrinologist at Children's Memorial, but not a specialist with this particular disorder. So, I don't really know what I'm asking. I guess you're saying I need to see a genetic counselor.
Well, it sounds like maybe you need genetics testing over again, so you see exactly what you're dealing with, right? You don't
I
really
guess,
know.
yeah. I guess there's 2 different types, it sounds like.
Well, yeah, it sounds like the first thing you need is repeat genetic testing.
And
You know,
with
so
our regular pediatrician, or we have specialists at Children's Memorial in Chicago, like, where would you go to get it, like that?
personally, I would go to a
Come
genetics,
here?
I would go to a genetics counselor at Children's Memorial.
I would reiterate that. If possible to get the results from 9 years ago, that would be great. If not, you might need new tests.
I have
Yeah.
them.
Yeah, so then take that to a genetic counselor.
Take that to a genetic counselor and have them explain
Yeah,
what
what the
my
options are.
Right, whether it proves one or the other, or whether you need it.
Okay, because that was confusing to me. I didn't even realize, even 2 years ago, I don't think that speech was given, that there were 2 different types, or there was.
Well, it's actually even more complicated. So,
More
so
complicated 2 years
modern,
ago.
you know, it would be appropriate to get some modern testing done and some genetics counseling. And then in terms of the endocrinologist, you know, again, there are some guidelines. They're not really evidence-based, so it's hard to say that what she's doing is right or wrong.
I mean, it's just the best hospital for us.
Sure, absolutely.
You're being way too kind. I mean, I think if you polled this audience, I think you'd find that 80 to 90% of the endocrinologists that we've encountered have been not very well informed and not very well up on.
Not like you.
And, I mean, that's the reality.
I just know what my
We visit
ignorance
once
is.
a year,
Yeah.
and she tells us if he's in puberty or not. And she deals with testosterone injections for all different reasons, not just for
Sure.
a chromosome disorder.
Sure.
So, I mean, that specifically, she's looking at when it's not testosterone, nothing to do with Klinefelters.
Sure.
My question would actually go with hers.
Okay.
Because my question is, because I'm from the Chicago area too.
Okay.
My son is an adult now. And it's very difficult to find an endocrinologist who wants to deal with it, who knows about it. I mean, I went to University of Chicago, which was children's hospital at the time, saw a pediatric endocrinologist, didn't even understand why I would want my child to be on testosterone before he was an adult. And it's very difficult when you have to do the educating for the doctors, because I don't know either. I'm supposed to be coming to them.
Sometimes
So I would like to know, is there any place, I mean, do you have endocrinologists throughout the country that you can recommend that we go to see, that you can talk to, or who have some idea of how to treat somebody who does have Klinefelters?
travel to Baltimore and see Dr. Dobbs.
Yeah.
She is terrific.
Well, I understand that, but like, okay, you're talking about insurance now, and it's like, can you get in? Will they take your insurance?
Yeah.
You know, I you have to fly around the country. It
Yeah,
becomes
sometimes what
cost
you have to
prohibitive
do,
sometimes.
sometimes what you have to do is to determine that it's a priority and that you're going to pay for it out of network. Then you go to a consulting center like Johns Hopkins, and they will work with your local doctor after they've made the recommendations.
So you can have insurance
You may
coverage.
have to, drive your old car for an extra year, or do without a new sofa, but it's really very important to go to the best doctors. And sometimes that means out of pocket
Initially.
but then they will work with your local doctors.
So you can have insurance coverage and get not good results or questionable results, or you can find the best place to go and figure out how to pay for it. And really, that's what it comes down to, because insurance coverage is going to get you nothing, generally.
One thing I would say is that although it is tough to get here or to Baltimore, the more that we actually see kids, the more, or adults, excuse me, that's a habit. The more we see patients, the more we're going to be able to provide guidance, the more we're going to know, the more we'll be able to provide guidance to others. It's actually quite difficult in peds right now to say, here's how you should do testosterone therapy, because we do not have the data to say this is the right way, that's the wrong way. And the best way to get that data is to have all the kids, as many kids as possible in one place, so that you can actually look at it.
You've had your hand up for a while, Ms. Ross.
I think that if there's anything that we all agree here is that we really find it difficult to find professionals who are informed. And you mentioned the different types of treatment, the different timing that there is to be able to provide that treatment. I would like to come out of here today with at least some knowledge that I can pass on to professionals that are working with my grandchild, who's the one who has 47 XXY, and that would at least help them have the proper treatment. So you are the experts. What kind of questions should we ask, or what kind of things should we tell our endocrinologists or our professionals to be able to get the treatment? Because unfortunately, most people cannot afford to go to Johns Hopkins. Most people cannot afford to come to Denver. I mean, these are the people that can afford it. I did miracles with points and gift cards and all kinds of things to be able to get here. And what kind of recommendations do you give us so that we can talk to our professionals? When I told my professionals for my grandson that we were coming here, their response was, oh, please learn a lot and share with us what you learned. Don't our professionals have a place to go to learn this information that we could tell them, listen, now we could tell them, you know what, Johns Hopkins has this, or isn't there a place where our professionals go to be able
Yes,
to stay up to date?
So a couple of things. One is, this was very brief. Each of us is giving a longer talk this afternoon. Those talks will be available to you. They're in your handout, I guess. They're supposed to be, and they're going to be online. You can use that to take to your physicians. I can tell you that Klinefelter, the management of Klinefelter syndrome is actually a relatively common topic at pediatric endocrine meetings. So people have the opportunity to go and learn from experienced clinicians about how to manage it. So that stuff's available. It may not be their priority when they go to the meeting to pick that session.
Yeah, and I mean, it's tough to hear everything that everyone here goes through. And certainly that's part of the reason that we'd like to make guidelines. Like I said, that's a goal. Unfortunately, we don't have it, but that's what we'd like to do. And that takes building up data, getting patients information, and having everything together, and being able to test, really, just do studies to decide what should be included in those guidelines. And also, as I was mentioning, a lot of the things are just an individualized approach based on so many issues pertinent to that patient. So I think that's part of, I totally hear you, it's hard for everyone to go to one or two cities in the country. But ultimately the goal is not to make people keep coming back, but rather to give them a regimen that we decide with the patient and family that they can take back and use with their provider in terms of both medication, monitoring, etc. Back to there.
I had a question and a comment. I know Jim Moore said he was talking about getting a list together of physicians across the country. We are from the Chicago area, and we did find somebody that is good and experienced and treats Klinefelter's patients and has been to this conference in the past. As far as the question I have to you all is, you had mentioned about harvesting sperm for men that do want to father children. Once they have had children successfully, is there any research or data that determines are their offspring going to carry the gene or develop the syndrome? Any one of these sex aneuploidy?
Sure. So none of us is a genetic counselor, but at the same time, in general, it's been surprising how very few of the Klinefelter fathers, how few of their children end up having, especially Klinefelter, but also sex chromosomal abnormalities. In general, I think it's around 10 to 15% is what we believe the rate of this global condition, but this is more thought of as a cell division problem rather than kind of passing on the Klinefelter gene, because it doesn't work that way, of course. But again, that would probably be best investigated with a genetic counselor.
Susan Howell, who spoke before us, who's around, is a great person to talk to about that. She's a genetic counselor.
Is your contact information on your handout?
So mine definitely is.
Yeah, the Hopkins USA number is what sort of that's our point.
Where did that fit into what they did to the entire hospital?
So Hopkins USA is a service at Hopkins that will coordinate visits for patients coming from all over the country. And so there's also like Hopkins International, Hopkins USA. And as part of that unit, they're familiar with our center and our scheduling procedures, and they know all the contact information. And so it's a bit of a job for them to contact all of us, try to figure out a date or a week in which all of the patients' visits could be scheduled, and work with our secretaries and schedulers.
Quick question, direct to you. I'm here with my 12-year-old son, XXY, and we're trying to figure out for after lunch. You're both giving I'm not sure if we split up or what would you recommend?
Well, tomorrow I'm going to give the same sort of general talk, except it's just for the children, as it were. So, there will be a chance. I mean, I'm happy for you to come to mine as well tomorrow. So if I had to choose, I could this today and mine tomorrow.
So you'll be doing basically a repeat tomorrow?
Yeah, I mean, it's going to be less formal. I'm not going to show slides.